All right, welcome everyone. We're going to be starting in about 1 minute. We're just waiting for everybody to enter the webcast. All right, welcome everybody who joined us. I still see some people logging in, so I'm just going to give it one more minute and then we'll get going. All right, well, welcome everyone to the Leukemia and Lymphoma Society of Canada's Living Well with a Blood Cancer virtual conference. Having to pause some of your life goals as you confront a blood cancer diagnosis may cause you a great deal of worry. When you're in and out of treatment or navigating a chronic blood cancer, taking care of your health and well-being are especially important. This week-long conference will offer you interactive presentations and expert-approved tools, tips, and recommendations to improve your quality of life so that you can live well with or after a blood cancer. So to get us started, I'll introduce myself. My name is Charlotte Hall-Coates, and I'm the Community Services Manager for the Atlantic region with the Leukemia and Lymphoma Society of Canada. I will be your host for today's event. This presentation will last approximately 60 minutes and will include a question and answer period at the end. Since there are many of you, we invite you to type your questions and comments into the Q&A box on your Zoom webinar panel throughout the presentation. An LSC staff member will monitor the questions. I will also read some of your questions aloud at the end of the presentation during the Q&A section. This conference is being recorded, therefore you can always come back and view it again on the LSC website. Before we begin our main presentation, I would like to share with you our mission and highlight some resources that you might find helpful for either yourself or someone that you know. Next slide, please. At the LSC, our mission is to cure blood cancers and improve the quality of life of those touched by blood cancer and their families. We offer guidance and support every step of the way. The community services managers across Canada can help. We are compassionate connectors that can help you cope with your blood cancer experience. Please do not hesitate to reach out to the community services manager in your area. You can reach us by email at info@bloodcancers.ca or by calling toll-free 1-833-222-4884. Next slide, please. The Leukemia and Lymphoma Society of Canada has many free services to help you through the blood cancer experience. One such service is our peer support program. It is a support service that matches people affected by blood cancer, caregivers, and their families with trained volunteers who have been touched firsthand by blood cancer. Whenever possible, participants and volunteers are matched based on age, diagnosis, treatment type, or the issue that is most concerning to them. Next slide, please. On our new website, bloodcancers.ca, you will find a variety of educational resources and support services. For example, there you can access free booklets and fact sheets containing information about specific blood cancers, treatments, and practical information. You can also find short animated educational videos, past webcast recordings, as well as access to our many podcast episodes. So I definitely recommend everybody check out the website. Next slide, please. All right, so it is now my pleasure to introduce our topic and speaker for today. Sleeping well with blood cancer, not always that easy. Sleep problems such as insomnia, poor sleep quality, and irregular sleep-wake patterns are common with people with blood cancers. Today, Dr. Sheila Garland will talk about what's getting in the way of a good night's rest and how to manage the underlying problems so that you can enjoy a more restorative sleep. Dr. Garland is a registered clinical psychologist and an associate professor in the Department of Psychology at Memorial University of Newfoundland. She is cross-appointed to the discipline of oncology. Dr. Garland completed her PhD in clinical psychology at the University of Calgary. She was awarded a 3-year Bisbee postdoctoral fellowship, a prize given to top-ranked application by the Canadian Institute for Health Research. She received postdoctoral training in integrative oncology and behavioral sleep medicine at the Perelman School of Medicine at the University of Pennsylvania in Philadelphia. Her clinical and research interests are psychosocial oncology, insomnia and sleep disturbances, cancer treatment, side effects, mind-body interventions, stress and health, and behavioral clinical trials. So thank you so much for joining us today, Dr. Garland, and over to you.
Thank you so much. And I am so just amazed to see how many people we have joining us today. So thank you very much for taking the time to attend. And yes, I'll be talking about sleeping well with a blood cancer diagnosis. And I always like to start out with just giving you my perspective on the importance of sleep with regards to other aspects of health. So, if you imagine sort of like sleep as this giant mountain here on which the house is sitting on top. So if that is sleep, that is how much of a contribution sleep has to your overall health. And it is at least involved, if not a lot, to a little bit in almost everything that we do, ranging from our immune function, our cognitive function. It regulates our appetite, it regulates our emotions, and it also helps with physical repair and restoration. So I think if we're talking about sleep, we do need to make sure that we've got a basic understanding of sort of the biology and the mechanisms of sleep. So I am going to take some time to describe how sleep works, because if we understand that, we can understand sometimes how sleep can go wrong. Okay. All right, so I'm going to take you into the brain now, right? So we all have heard about REM sleep and non-REM sleep, but maybe we don't actually understand what that means. So we do sleep in 4 different stages. 3 of them are classified in the non-rapid eye movement group, and 3 of the other one is the REM sleep, which is the rapid eye movement group. And I want to move my picture down here. All right. So with REM sleep, or non-REM sleep, that includes 3 stages. And you can see here, these are the measurements of our electrical activity of our brain when we're awake. So you can see that our brain waves there are very, very low, very close together, and they're very fast. So there's a lot of them. It's, kind of like if you were going to take a scribble with a pencil and just go like this, right? That's called alpha waves. So our brain is doing that when we're awake and we're relaxed. As we progress into stage 1 sleep or stage N1 sleep, this is our lightest stage of sleep. And we can see another particular type of brain pattern emerging. So we see these are like theta waves. So we're seeing that our brain waves are kind of slowly spreading apart. If you can imagine your brain slowing down, this is where it starts to slow down with those theta waves. Stage 1 sleep is the lightest stage of sleep. It's the stage where we're most easily able to be awakened. If somebody calls your name, if you hear a door slam or something like that, you're likely to wake up. It's also the stage that people might experience what's called hypnic jerks. So if you or somebody you're observing, you see like them sort of twitch or jump in their sleep, those are what are referred to as hypnic jerks. And it's basically just a sign that you're getting into sleep and you're in stage 1 sleep. So completely normal to have those hypnic jerks in stage 1 sleep. Then we progress into stage 2 sleep. And then you can see even more that our brain waves are getting bigger, they're larger in amplitude, and they're spreading out some more. So we even see some other unique brain patterns starting to observe. So this one's really big and really far apart. That's called a K complex. So that's coming into stage 2 sleep. And then we also have what's called sleep spindles. And so these are like concentrated little pockets of like really dense levels of electrical activity in our brain. So I conceptualize stage 2 sleep as sort of like the intermediary. These, concentrated pockets of electrical activity allow us to move back into a lighter stage of sleep, whereas these K complexes, these, higher amplitude spread apart electrical activity in our brain, it allows us to go into a deeper stage of sleep. We spend about 50% of our time in stage 2 sleep. So it has a lot of functions, and we're still learning a lot about it, but it plays a role in some memory. So when we go into stage 3 sleep, this is often called slow wave sleep. And you can see, right, by the waves that they're very high in amplitude and very spread apart. And if you compare those to when we're awake, or even, in our lightest stages of sleep, our brain is doing something very, very different during this slow wave sleep. So this slow wave sleep, if you can imagine our brain being very slow during this time, like really slow, what the body and brain are doing during slow wave sleep is the brain is kind of offline, right? Like it's really relaxed, it's doing its thing, and the body is actually prioritizing more of the physical repair and restoration. So, for example, in kids, they spend a lot of time in this slow wave sleep, and this stage of sleep is responsible for a lot of the growth hormone, a lot of the regulation of physical repair and restoration. So we think about slow wave sleep. We think about physical repair and restoration. Okay. And then if we go to REM sleep, this is often most associated with dreaming, because our brain patterns during REM sleep are very consistent with when we're awake, right? They're very small in amplitude, very, very close together. So REM sleep is responsible for more of the emotional components of our day. So it's processing the emotional things that happen during the day. It's processing the events. It's taking things from short-term memory and putting them into long-term memory. So the brain is very, very active during REM sleep. We do have our most vivid emotional dreams in REM sleep, but we will have other dream content in other stages, but it's a different quality than the dreams that we would have in REM sleep. And so what we do is we cycle through various stages throughout the night. The other thing that's particularly unique about REM sleep is that during REM sleep, our body, our ability to move our major muscle groups is turned off. So we're basically, for all other intents and purposes, our body's paralyzed during REM sleep. We can't move during REM sleep. And it's thought that the function of this would be to prevent us from acting out our dreams. So that's why, we can do things that are amazing during REM sleep, jumping from buildings or, running race, and we don't have to worry about us actually acting out those very vivid emotional things that we're doing. So that's where that is a particularly unique feature of REM sleep. It's also why some people will experience what's called uh, sleep paralysis. So this is where they feel like they've woken up, but they're not able to move their major muscle groups. This usually only lasts about 30 seconds or so, and then people sort of are able to move their major muscle groups again. But it can be very scary. And so, if that has happened to you, you can also realize that it is a normal phenomenon that people experience, and basically, it's just your awareness part of your brain, the frontal lobe of your brain, has woken up prior to the more kind of basic part of your brain and the brainstem, which has closed off your ability to move your major muscle groups. So all the frontal lobe has to do is sort of give a nudge to the back, the basic part of your brain, and say, "Hey, wake up," and then that's what happens. So, all right. So now this is where we actually cycle through our sleep stages throughout the night. So if you see here, we might spend a little bit of time awake during the beginning of the night, and then we're going to go down and we're going to spend some time in stage 1, stage 2, and then we're going to spend time in stages 3 and 4. That's that delta sleep, that slow wave sleep combined. And then we're going to come back up, stage 2, stage 1, have some REM sleep right there. Then we're going to go back down in stage 2, spend more time in stage 2, a little bit more slow wave sleep, delta sleep, stage 2, skip stage 1, go up, have larger REM. Then we might have an awakening. We might decide, oh, we need to go to the bathroom or turn over or something like that. And then go back down and into stage 1 and 2, back up, longer REM, 1 and 2, might have another awakening here, and then some more REM, more stage 2, and then we wake up. But if we put a kind of an arrow, right down in the smack dab in the middle of the night, if you compare the first part of the night to the second part of the night, you're going to know that there's different things happening. So in the first part of the night, our body is actually prioritizing that repair and restoration. So we're getting way more of that slow wave delta sleep in the beginning of the night. And in the latter part of the night, we're getting more of the REM sleep. Now that I've showed you how our brain waves are during each of those sleep stages, it might make sense why, right? If our brain waves during that slow wave sleep are really high and far apart, it's going to be very hard to wake up from when you're in delta sleep. If somebody has, with kids, right, they can fall asleep at a party. You can throw them over your shoulder. You can put them in the car seat. You can drive them home, take them out of the car seat, put them in their bed, right? They're still sometimes don't even wake up. Like that's like how deep delta sleep or slow wave sleep can be. Also, if people have had too long of a nap, right? Maybe gotten too far into that slow wave sleep. When they wake up, they feel groggy. They feel like slowed down. And, the nap actually makes them feel worse. That's an indication that you've gotten too far into that slow wave sleep. So we want to make sure that our brain is better able to transition from sleep into wake. So that's why the REM sleep is prioritized during the morning hours, and the physical repair and restoration is prioritized into the early sleep time. The other reason that this is because basically, like if you're not able to get a full night's sleep, for whatever that might be for you, for whatever reason, like, maybe you've got a child, your child wakes up in the middle of the night, you need to attend to them, there's an emergency, you need to, car alarms going off or something else like that. At least your body has received that physical repair and restoration. You might not feel cognitively very there, but at least the physical repair and restoration was taken care of. So the body is very, smart in that way, right? It's prioritizing our physical, and then, we get the emotional and the cognitive stuff a little bit later on in the night. So this is probably the most depressing slide that I'm going to present today. So this is how our sleep changes across the lifespan. Now, one of the things that doesn't change is normally once we get into adulthood, our sleep, the total amount of sleep that we need doesn't change all that much. So you don't go from being a 8-hour sleeper to a 5 or 6-hour sleeper. It might change maybe a half an hour to an hour maximum, but really not much more than that. But the time that you spend in sleep stages does change. So you can see here with kids, right? They're spending a lot of time in that slow wave sleep, that delta sleep. That's the one that I said was important for like growth and repair and restoration. So they're spending a lot of time in that. And they're also spending a lot of time in REM sleep, which is, because their brains are growing and they're making all of these new neural connections and everything else. But once you get to be in your, adult years, a lot of things level off. So, the time you spend in REM sleep and stage 2 sleep, those pretty much stay the same. The slow wave sleep here is the biggest drop off. Right. And again, this makes sense if we understand that the slow wave delta sleep is responsible for physical repair and restoration. Our bodies just don't heal themselves as fast as they used to when we were kids as we get older. And so, sometimes when I've given this presentation, people have asked, how can we, increase the time that we spend in slow wave sleep, and I would say that is, the whoever can figure out how to increase the time in slow wave sleep would have, the ultimate sort of pill to longevity or long life, because, it is such an important sleep stage for our physical repair and restoration. The amount of time we do spend in lighter sleep, our stage 1 sleep does slightly increase, but really what we see happening is we tend to spend more time awake in bed than when we were younger. And we'll talk about how that can be a problem. So everybody asks sort of what is the optimal amount of sleep? What total sleep time should I be getting? And it really does depend on your age, right? So, we've got the optimal times here. That would be like the range. That would be kind of like most common. But then we have ones on either side of that range, which might be acceptable for people. But anything outside that range is sort of getting into trouble. So you can see that, kids are needing the most, anywhere from 14 to 17 hours for newborns, 12 to 15 hours for infants, 11 to 14 hours for toddlers, 10 to 13 hours for preschoolers, 9 to 11 hours for school age kids, 8 to 10 hours for teenagers. And I can tell you that teenagers are definitely not getting that amount of sleep. Perhaps COVID increased the amount of sleep that they were able to get because they didn't have those early class times, maybe. But this is a big problem for teenagers. And then young adults, 7 to 9 hours from 18 to 64. And then older adults, 7 to 8 hours or so. And this is what I mean, that it really doesn't change too much, maybe an hour or so. And it can be as low as 5, and it can be as high as 9 in the older adults, or as low as 6 and as high as 10 in the adults. So it's also important to understand what regulates our sleep, because again, if we know what regulates it, we'll know how it goes wrong. All right, so this is the first thing. So the first thing that influences our sleep is something called sleep drive. And I'm going to refer to this as sleep drive or sleep pressure. Both of those things mean the same thing. And so what this is it's driven by a neuromodulator called adenosine. And so from the time we wake up, this accumulates in our brain during waking hours. And this increase in the accumulation produces sleepiness. So it keeps on increasing from the time we wake up. And then when we go to sleep, it decreases during the night. And then the stores of this neuromodulator adenosine in our brains diminish. So interestingly, adenosine is the neuromodulator that binds to caffeine. So caffeine works on this system to make us feel more alert because it temporarily reduces our sensitivity to recognizing the buildup of adenosine in our brains. But it only lasts, roughly, 6 hours or so. So then after that, you can experience a crash. So we want to be able to use this sleep drive to our advantage. So there's a number of behaviors that make the sleep drive weaker. So remember when I said that as we get older, we spend excess time in bed or more time in bed than we used to. And this is a behavior that can weaken the sleep drive. Also, if we nap, either if we're napping too long or if we're napping too close to bedtime, this can also weaken the sleep drive. So napping, now that we know about sleep stages and how long it takes for us to move through our sleep stages, an ideal nap should be long enough to not get you into that slow wave sleep. So that would be roughly a half an hour or so. And that's when you can use a nap to get the alertness benefits, but it's not going to get you into slow wave sleep. And so you're not going to feel that kind of grogginess. Naps that are too long cannot be as restorative unless you're allowed to go through your sort of full cycle. So then it becomes not really a nap, but like a short sleep, because each sleep cycle is about 90 minutes or so. So it's either you have to have a nap that is 30 minutes or less, or you need to have a nap that is 90 minutes or more in order for you to actually be restorative for you. If you nap too close to bedtime, that's pretty powerful because it reduces the amount of adenosine that's built up. And so if you want to fall asleep at your regular bedtime, you're not going to have enough to be able to help you facilitate that sleep time. with dozing. Now, I differentiate napping and dozing because sometimes people will say, oh, no, 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 I don't nap. I don't nap. But I'll say, well, what about dozing? And this can be like in the evening time watching TV or something. People might, kind of just find that their head's nodding. And so that can be dozing. And that is, those can be really, really powerful sort of micro sleeps that can also discharge some of that sleep drive. And then sleeping in on weekends can weaken the sleep drive or make it become irregular. Because if your adenosine doesn't start building up until you wake up and you're waking up later, then it means that you're not able to fall asleep at your regular time. Okay. So if you think about what happens, usually when somebody has a cancer diagnosis, if they're taking time off work, let's say their typical work schedule, they would get up at 6 o'clock in the morning because they needed to be at work by 8 or 8:30. And so let's say that they didn't have any trouble falling asleep prior to their cancer diagnosis, and they would regularly get about 8 hours of sleep. Okay, so these are just some numbers for you to keep in mind. So if they wake up at 6 o'clock and they're an 8 hour sleeper, if you take 8 hours away from 24 hours in a day, you have 16 hours of sleep pressure or sleep drive that needs to build up. Okay. So, for example, if somebody's waking up at 6 o'clock in the morning, if you go ahead 16 hours, that's going to be 10 o'clock at night. So you can either go ahead 16 hours or you can cheat like me and go back 8, right? So you can kind of predict based on the time they wake up and their sleep drive, the amount of sleep drive that they're going to need, sort of around what time they're likely to fall asleep. Okay. So that would put their bedtime around 10 o'clock. Now, but what happens when somebody has a cancer diagnosis? Maybe they're taking time off work, or their schedule has changed, or they're feeling sick and they're, feeling awful, or then they might say, why would I get up at 6 o'clock in the morning, right? I have no reason to get up at 6 o'clock in the morning. So maybe they stay in bed till 8 and they stay in bed till 9 or 10 or, anything else like that. And then what happens is it doesn't mean that their sleep need has changed. They haven't, automatically now become 12-hour sleepers. But if you are changing your wake up time and you're waking up at, let's say, 10 o'clock or even 9 o'clock in the morning, if you go back 8 hours, that you're not likely to fall asleep until 1 or 2 if it's 10. But when people aren't aware that this is one of the really, really important mechanisms that regulate their sleep, they say, well, I've always gone to bed at 10 o'clock. That's what time my partner goes to bed. I have my routine. I, read my book and everything else like that. And then why now all of a sudden I can't fall asleep, right? So that can explain why people can have that sleep onset difficulty, is because they have changed their morning wake up time. It's either that happens, or they're able to fall asleep, but then they have a 3 hour or so awakening in the middle of the night, either in one big chunk or in a couple of chunks, and then that's where their extra time is spent awake during the middle of the night. So it either kind of shows itself at the beginning of the night, or it shows itself in the middle of the night. So, one way to optimize your sleep drive, to use this to your advantage, is sort of like identify for yourself what your typical sleep duration is and decide on a wake time. Decide on a time that you can keep relatively consistent, 7 days a week, and then subtract your sleep duration from that wake up time, just exactly like I did in that example. And then you've got an estimate of when your time to bed should be, or the estimate of when you'll fall asleep. And most of the time, people, after they keep track of this for a little while, they're like, wow, it actually does roughly coincide pretty nicely. The other mechanism that influences our sleep is something called circadian rhythm. And this is our body's built in clock. And it's very much a biological thing. It's centered in the hypothalamus in our brain, and it controls our sleep, regardless of how long we slept the night before, or how long we were awake. This is why there's certain like times during the day that no matter how much we slept or didn't sleep the night before, we will be unable to sleep during that time. So the sleep drive, if you can imagine, that is pushing down on us. That's promoting sleepiness. The circadian rhythm is pushing up. This is promoting wakefulness, right? And so this is coordinated largely with the day cycle, with the night. With the light dark cycle over the 24-hour period. But it's also very much influenced by our eating, by our regular exposure to food, by our core body temperature, by our physical activity. But it does influence, like, how our cells regenerate themselves, our hormone production, everything else like that. So it's circadian rhythm has a rhythm for almost every part in our body. So we want to be able to entrain this circadian rhythm to make it stronger. And we can do this by, again, waking up and getting out of bed at a regular time. And then the amount of light exposure that we get and the timing of that light exposure. So I'm with the rest of the sleep science community, where we very much advocate for a return to standard time. Standard time, so now, is more in line with our body's regular circadian rhythm. We want to have bright light in the morning. We want to make sure that that light goes in through our eyes and can turn off the production of melatonin in our brain. We don't want the light in the evening, because when we want, that's when we want our body to start recognizing it's dark, to start producing its own melatonin. So we want to make sure we have bright light in the morning, and we want to make sure we don't have that exposure to bright light in the evening. And we can also reinforce this by making sure our other activities are regular. So I mentioned meals, having regular meals, and exercising. We want to exercise either in the morning or in the middle of the afternoon. Exercising, particularly exercise that gets your physical heart pumping, really gets your blood moving, gets your heart rate up. That can increase your core body temperature, and a high core body temperature can make it harder for you to fall asleep. So, but having that high core body temperature is good in the morning because it's associated with wakefulness. Okay. Now, these are these two systems as they work together. So we just to orient you to this figure that I have here, we've got 2 days. So between 7 in the morning and 11 at night, somebody's awake. And then from 11 to 7, somebody's asleep. And then again, 7 to 11 awake, 11 to 7 sleep. So this is the circadian rhythm. So the circadian rhythm is promoting wakefulness. So you can see it's really, really high, sort of peaks in the middle of the afternoon. And then we've got it decreasing steadily over the period where we're wanting to fall asleep and when we're partially in a sleep window, and then rising again to make sure it's promoting wakefulness when we wake up. Just interestingly, there's a little blip that's not captured in this figure in our circadian rhythm promoting alertness in the middle of the afternoon around 3 p.m. So that sort of like dips, and it's that lessening of the wakefulness promoting circadian rhythm that causes that period of sleepiness in the mid-afternoon. So it doesn't have to do with having a big lunch. It doesn't really have to do with having the sleep you had the night before. It's just during that period, our circadian rhythm is not as strong, promoting wakefulness. So this is our sleep drive. So you can see from the time we wake up, our sleep drive just continually sort of accumulates adenosine. And then what happens is when there's the biggest difference between our sleep drive and our circadian rhythm, our sleep window opens. And so this is when would be our ideal time based on our own physiology and chronotype. And chronotype would be whether or not you're like an early bird or a night owl. So this sleep window can change depending on your own individual sleep preferences. But that's when, we're most likely to be able to fall asleep. And then our sleep drive discharges and then starts building the next day. So this is when it sort of works really well together. But then what happens is we have this mechanism called our arousal system, right? This is our fight or flight, our stress system. And so we have our sleep drive and we have our circadian rhythm. And, ideally, that's all. That's all we would have to rely on. But then what happens is our brain can get in the way. So you can see here, this person's lying in bed at 10:30 and the brain says to it, okay, let's revise some of the dumb stuff you said today. This could take a while. And then at 11:17, she's closing her eyes and she's thinking, okay, great, I'm going to get some sleep. And then the brain says, wait a minute, just quickly, remember that argument you had 6 months ago? Right. And then the woman's like, eye starts twitching, like, oh, right. I don't want to relive that. And then the woman's saying, like, what now? The brain's saying, you're going to look really tired in the morning. So anybody who's had difficulty sleeping might recognize this pattern where like our brain can actually make it so no matter how tired we are, our brain kind of turns on and we start thinking about things. So, our body, as much as it is, brilliant, it can also get in the way of what's best for us. So, for example, like our body responds the same to actual threats. Right. So, like, if you needed to get up in the middle of the night to attend to a baby or to attend to a fire or something like that, you want your stress system to kick in because you don't want to be sluggish. You want to be able to like physically be there and be on and be able to attend to it. But our brain and our body also react to the same way to threats that we might create for ourselves. So that might be like, we're mad about something, we're worried about something. And it could be, as much as it could be like, I'm going to look awful tomorrow if I don't get enough sleep tonight. I'm going to make a mistake tomorrow at work, or I'm going to be miserable. It's going to impact my physical health, and then our mind just goes off on a whole nother sort of tangent about all of the reasons why our sleep is going to make life worse for us. And then, of course, that makes it even harder for us to fall asleep. So we can be really, really tired. We can have a really strong sleep drive. We can be right in our appropriate window based on our circadian rhythm, and then our brain can get in the way. And that's where insomnia happens. So, how do we define insomnia? So, this can happen just like depression. People can be depressed or have a depressed day, but not necessarily have depression. People can have a night of insomnia and not necessarily have insomnia disorder. So, it's normal to have the occasional night of sleep difficulty, but when it becomes a syndrome or a disorder, it needs to occur for at least 3 nights per week, despite adequate opportunity for at least 3 months. So that's where you would characterize it from just like the occasional night to an actual sleep disorder. And if you think about what that difficulty sleeping would look like, it's usually a dissatisfaction with sleep quality or quantity characterized by either taking longer than 30 minutes to fall asleep. If you're awake in the middle of the night, it takes you more than 30 minutes to fall back asleep, or you might wake up earlier than you intend to and not be able to fall back asleep. And these problems are causing you trouble, right? So they're accompanied by distress or impairments in daytime functioning. So irritability, mood, concentration, those sorts of things. Now, insomnia in people who have had a diagnosis of cancer is extremely prevalent. So this really depends on the stage at which the assessment takes place. So we know it's very high at the time of diagnosis, and it usually kind of peters off after that. But roughly 30 to 50% of people diagnosed with cancer will report difficulties with insomnia. It does vary depending on cancer type, as I mentioned, time of assessment and also method. So if we're doing an insomnia interview or if we're just doing like a self-report. But just to give you a bit of a reference, the prevalence of insomnia in the general population is roughly 10 to 15%. So, you're looking at 3 to 5 times higher in people who are diagnosed with cancer. Now, there's a number of really good reasons for this. One of them would be that anxiety and depression make insomnia more common, right? If you're thinking about all of the things that could happen, you're worried about your future, you're upset about things that have happened in your past. Those are things that we often try and push aside during the day, but that can come back up when we're trying to fall asleep at night. So that makes it more likely that people with cancer would have trouble with sleep. Chemotherapy itself has been associated with a disruption in those circadian rhythms. So, if we assess circadian rhythms after each successive course of chemotherapy, we see these rhythms get progressively dysregulated. So they're not as strong, they're not as entrained. And this can be because of the physical consequences of the chemotherapy. So, they're whether it's making you physically ill, you're not feeling well enough to do the things that you would normally do. Medications, especially steroids. Excuse me. I hear a lot of people tell me that their physicians, that their oncologists didn't warn them about the sleep consequences of the steroids that their chemotherapy was either accompanied with, or the steroids that were given in advance of the chemotherapy. And so these steroids increase agitation and have direct impacts on sleep. Without that warning that these steroids are going to impact sleep, people can become very concerned. Why am I not sleeping? This is horrible. Sometimes just the knowledge that the steroids are what's causing some of the sleep difficulty, and once the steroids are less or not around anymore, your sleep should recover, as long as you don't do things in the meantime that can make it more likely that they're going to persist. Hormonal treatments can cause or worsen hot flashes. And then other factors include, pain, discomfort, overall fatigue. So because of all of this, it's really not surprising that insomnia is so much more prevalent. So insomnia is also not something that you should just take lightly. Insomnia can make other things worse. So it can make physical and mental health problems worse. It can increase levels of pain, fatigue, anxiety, and depression. We have some evidence that because of the importance of sleep for immunity, poor sleep can increase risk of infections. And it also can contribute to overall poor quality of life, and even, way past post-diagnosis, so 10 years. When we look at those who have good sleep, now I'll say that this was measured in women with metastatic breast cancer. Good sleep quality is associated with an overall reduction in mortality in women with breast cancer. So, there could be protective effects of good sleep. So, there are a number of insomnia treatment recommendations. The first one was put out by the American College of Physicians, and this is their clinical guidelines. So this goes out to all the physicians in the United States, but also it should make its way over into Canada as well. They talk about cognitive behavioral therapy for insomnia as the recommended initial treatment for chronic insomnia, and they gave this a strong recommendation. With regards to sleeping medications, they say that clinicians should use a shared decision-making approach, including a discussion of the benefits, harms, and costs of short-term use of medications to decide whether to add medications to add pharmacological therapy in adults with chronic insomnia disorder, for those who couldn't access cognitive behavior therapy for insomnia, or if it was unsuccessful. So this was a really big thing, because this is the big group of physicians recommending a non-medication based treatment. So what exactly is cognitive behavior therapy for insomnia? And so I'll give you a little bit of a graphic here. So that intervention targets behaviors. So there's a number of things that we can control that will influence our sleep. So this is just some guy who sitting there saying, I spend all day hunched over a desk, railing my coffee, staring at a glowing screen and reading the news. And then for some reason, when the sun sets, I can't seamlessly transition into calming down enough to fall unconscious. So we have sometimes unrealistic expectations of ourselves. We think that we should be able to just be, go, 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 and then fall asleep quickly, stay asleep, and then get up and go, 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 go again. But when I mentioned our thoughts before, maybe some of you also relate to this. So I do a lot of thinking before I go to sleep. I play scenes in my head. I practice the things I want to say. I have endless what ifs. I make plans for the next day. I think of all the people I miss. I think of all the ones I hate. I ask myself a lot of questions. So, all of those things are really counterproductive to falling asleep at the end of the day and the disengaging from the day. So those are the sorts of things that cognitive behavior therapy for insomnia targets. Now, when we think about how insomnia develops and why it persists, I can take you through this model to give you an understanding. So, everybody has factors that make it more likely that somebody would develop insomnia. So, these would be things like, age, increasing age is associated with increased insomnia. Females are twice as likely than males to develop insomnia. If we have a sort of an anxious sensitivity, if we tend to be more likely worriers, that can make it more likely that we experience insomnia. So these are things though that stay constant over time. So this is pre-morbid, no trouble. This is acute in the 1 to 2 week. This is short term, and then this is chronic, where we have greater than 3 months of experiencing insomnia. And this is insomnia severity here, and this is the threshold. So anytime these bars get over that threshold, it's would be considered clinically significant. So then in the precipitating factors, this usually happens. This is something that either one thing or a combination of things that happen that put us over the threshold for experiencing insomnia. Now, this could be the cancer diagnosis itself, right? So, you get the cancer diagnosis and you can't sleep, especially in those first, 1 to 2 weeks. You've got a lot of questions. But in the short term, you've met with your treatment team, you've rallied your support network, and the impact of that cancer gets less. Right. So you're like, okay, you know what? I know what my treatment plan is. I'm not feeling as, anxious as I was before I knew that. And then, chronic, you might have a routine and you might have things down. Right. So the impact of that cancer diagnosis, decreases with time. But then what happens is we would start engaging in behaviors that would perpetuate or make it more likely that the insomnia would stick around. So, for example, we might start sleeping in. And now that we know the basic mechanisms of sleep, we know how sleeping in can make it hard for us to fall asleep. But, of course, after a bad night, we think like, oh, I've only had 3 hours of sleep last night. Like, I'm not going to get up and be functional. Like, I might as well sleep in. And actually, it's better not to sleep in because then it's not likely to perpetuate the insomnia the following night. Whereas if you sleep in, it's likely to perpetuate it. So it's almost like we have to take a little bit of a short-term hit in order to make sure that the insomnia doesn't stick around. Taking sleeping medications can become a perpetuating factor because it lessens our own belief in our own ability to fall asleep. Now, sleeping medications have a purpose, and they're particularly good during those times when people are on steroids, because steroids they can't really do anything about. So sleeping medications are intended for short-term use, but they're not intended for long-term use. Other perpetuating things might be going to bed earlier and trying harder to sleep, right? People have tried this. They go, I really need some sleep tonight. I'm going to go to bed at 8 o'clock. I'm going to try harder. I'm going to close my eyes. I'm going to try. And then 11 o'clock, they're just ticked off and frustrated, and they've just wasted, that amount of time not falling asleep and being frustrated. And then eventually what happens if you repeatedly pair your bed over and over and over with unsuccessful sleep experiences, you eventually develop a conditioned arousal between the bed and being awake. This is why people can feel exhausted. They can be like, their heads bobbing, they're falling asleep on the couch, and they think to themselves, oh my gosh, this is good. I'm going to get a good night's sleep tonight. And then all of a sudden, they're up in bed. And as soon as they get into bed, their head hits the pillow, their mind turns on, and they start thinking about things. This is evidence that there's this conditioned arousal. And this isn't the only time we develop these conditioned associations. So, for example, if you repeatedly pair the television with snacking, right? It doesn't matter if you just, had a meal. If you go down to sit in front of the television, sometimes you can feel yourself become a little bit peckish. And so if we repeatedly pair the bed with unsuccessful sleep experiences and thinking and planning and worrying and, all of that kind of stuff, it can be the cue to elicit that arousal. Now, there's a number of other ways that sleep can go wrong, and especially in people with cancer, obstructive sleep apnea is very common. And so this is either a partial or a total blockage of the airway during sleep. So some of the symptoms include witnessed or reported snoring. Apneas would be periods of not breathing. If you wake up in the morning and you have a headache or a dry mouth, night sweats. If people are carrying excess weight on their bodies and their airway on their chest, sometimes that can make obstructive sleep apnea more of a risk. If they have a narrow airway, this might be excess tissue around the back of the neck. If they have a large neck circumference, so this is guys who have to buy really large collars, right? Or if they have a recessed jaw, all of these things might make obstructive sleep apnea more common. So this is one of those at-home sleep tests, right? So this is basically somebody without sleep apnea. This is heart rate right here. These up and down, that's nasal pressure. This is your oxygen saturation. And this is whether or not the person's laying on their back. And then down here, you can see that's whether or not they're snoring. So that's a person with no sleep apnea. This is a person with sleep apnea. And this is only 30 minutes. So as you see here, only 30 minutes. So you can see these periods right here where there's no nasal pressure. Each of those is an apnea. So each time they have a blockage in their airway, their heart rate drops, their oxygen saturation drops. It's extremely hard on the heart. You might hear somebody, it would be like snore, 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 stop. And then big gasp, snore, 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 stop. So it's really, really hard on your heart, very, very hard, and associated with a lot of negative adverse cardiovascular outcomes. Sleep apnea treatments include continuous positive airway pressure. If we know that it only occurs on, when somebody's sleeping in a certain position, there's ways that we can get them positioned appropriately. If it's due to airway, there's dental devices or surgery. So I would really encourage anybody who has those symptoms or their partner or anything like that to really get it checked out because of the impact it can have overall on health. I know also restless leg syndrome is very common, especially in people with blood cancers. So this is characterized by like a tingling, creepy, crawly twitching in the feet, legs, and calves. Particularly in the evening, it can lead to insomnia because you can't relax. It is made worse by caffeine, alcohol, antihistamines, and certain antidepressants. So if you're on antihistamines or antidepressants, you're experiencing restless legs, you may want to switch to a different medication. You may want to avoid alcohol or caffeine because they can make them worse. There are a number of effective treatments. There are medications, prescribed medications. But before you go that way, you'd want to make sure you get your iron checked because low iron is also common in patients with blood cancers. So low iron has been associated with restless legs as well. So supplementing iron can be helpful. And then also supplementing with magnesium and calcium can also reduce the restless leg syndrome severity. So magnesium is a natural muscle relaxant. It can help with like Charlie horses, leg cramps, and then restless legs. The calcium just helps the magnesium be absorbed. And lifestyle, making sure that you're, getting enough physical activity during the day. So I wanted to summarize. So all of this, I've got 5 sleep better rules for you based on science and that incorporate some of the principles of cognitive behavior therapy for insomnia. So the first one is wake up at the same time, regardless of how many hours you slept, and including weekends. Now, of course, people who work shift work and everything else, there's accommodations that can be made for those cases. But generally, keeping your wake up time consistent is really important. People were given bad advice for a long time. They were told, go to bed at the same time every night. And it's actually the backwards. It's the opposite. So it's waking up at the same time because your wake up time determines your bedtime based on sleep pressure. And then make sure you get morning light exposure for at least 30 minutes within 1 hour of waking. So obviously outside light is the best, but if you can't get outside light, there are the light devices. Now, I have some research that supports the use of those light devices for also improving cancer-related fatigue, cognition, and mood. So those light devices can be just like the size of like a Palm Pilot or like a hand, or they can even be glasses that you can move around. Those can be very helpful for making sure that your circadian rhythm is very well entrained and can help with mood and energy. My sleep better rule number 2 is designate a clear your head time. Recognizing that we often keep ourselves very busy. We often avoid things that make us uncomfortable or bring up difficult emotions. And if we just avoid them, they're going to come up, right? We can't push them away, but they usually come up when we don't want them to come up. So outside of a therapist's office, designate, 30 to 40 minutes devoted to problem solving, planning, or worrying in the early evening, right? You want to just basically take all of that thinking you'd be doing in your bed, and then give it another time that it's not going to impact your sleep. And then remind yourself, if it comes back up, that you've already devoted time to it. My sleep better rule number 3 is designate a 90-minute buffer zone before your intended bedtime. So if you did the math that I recommended earlier and you've set yourself up with a morning wake up time and then you've gone back your total sleep time, then you have roughly what your target bedtime will be. Go back an additional 90 minutes from that and then make that your buffer zone. So, in this time, turn off your backlit devices, put them away, engage in things that are sedentary, pleasant, relaxing in dim light. So, if your target bedtime is 11, this would start at 9:30. And so these are things that you do just for you. Maybe you're reading. Maybe you're listening to music, maybe you're listening to podcasts, maybe you're doing your nails, maybe you're having a bath, maybe, you can do your routine or something like that. But, just prepare your body and your mind there to just relax. Sleep better rule number 4 is do not spend time in bed trying to sleep. Time in bed resting is not as good as time in bed sleeping. So, the more time you spend in bed awake, the more you're strengthening that association between the bed and being awake. You don't want your bed to be associated with rest, especially if you're resting while you're awake. You want your bed to be associated with sleep. So if you're not asleep within 30 minutes in the middle of the night, or if you find yourself awake for more than 30 minutes, or no, so if you're not asleep within 30 minutes at the beginning of the night, and if you are awake for more than 30 minutes in the middle of the night, or you find yourself getting frustrated, get up, go somewhere else and wait there. Do the same things that you were doing in your buffer zone. So, doing something pleasant, sedentary, dim light with no backlit devices. And then when you find yourself getting sleepy, your head is bobbing, go back to bed, and then try to fall back asleep in bed then. Don't go to the couch and then fall asleep on the couch because you don't want your couch to be associated with sleep. You want your bed to be associated with sleep. So that's why it's important to return to your bed and not go into a different bed or not go onto the couch or something like that. This is really, really important. It's very difficult to do, but it's really, really important to do because you do want to make sure that you give your bed the strongest cues for sleep it can get. And then sleep better rule number 5. When we stress about a poor night's sleep, that can cause us to do things that aren't in the best interests of our sleep overall. So it can cause us to cancel our daytime activities that might actually help us feel better. So, if we say, oh, I'm not going to go to the gym because I just didn't sleep very well last night, going to the gym could be the best thing for your sleep, right? It can give you that a little bit of adrenaline. It can get your it can get your body moving. You'll feel more alert. So, going out with friends, even, right? Don't cancel that because that could also give you a bit of a mood boost. So, emphasize your ability to cope with the effects of poor sleep. And I always I advocate strategic use of caffeine as long as that's something that's okay with you, especially in the morning. Just don't have caffeine past 2 or 3 p.m., especially if you're sensitive to it. But also saying, like, I'm really tired today. I'm going to sleep better tonight because I have so much sleep pressure built up because I didn't sleep well the night before. So it's kind of like changing the narrative around like the stress of like, oh, I'm not going to be able to sleep. What if I don't sleep too? It's a good thing I didn't sleep very well last night. My sleep drive is super powerful. I'm going to sleep well tonight. So you're just emphasizing the ability to cope with poor sleep. So we do have a study that is open to anybody in Atlantic Canada right now. If you're experiencing insomnia and you also have troubles with your memory, concentration, and attention, if you've completed treatment, and this can include surgery, transplant, radiation, or chemotherapy at least 6 months ago, if you're on any continued hormone or maintenance therapies, that's fine. And as long as you're considered cancer-free or in remission, we're actually providing cognitive behavior therapy for insomnia virtually via Zoom to people in Atlantic Canada. So you can always contact us there at the information provided if you want more information about that study. If the study is not appropriate to you, I would refer you to these additional resources here. So these are two books that are by Canadian colleagues of mine. So Judith Davidson from Queen's University and Rachel Manber at Ryerson. Both of those are very good, helpful kind of self-help manuals or workbooks that are based on evidence-based cognitive behavioral for insomnia principles, and can be very, very helpful. So I think I'm right on time here for questions.
Perfect. Well, thank you so much, Dr. Garland, for sharing your expertise and insights with all of us today. We do have time for the question and answer period. If you haven't already done so, please type your questions into the Q&A box on your Zoom panel, and we'll try to get to as many as we can. If we don't get to your question, we will try to answer it offline. So I know a bunch of questions came in during the presentation as well as submitted before. So someone asked about wearable technology and how accurate are they in recording your sleep stages and sleep time?
Yes, so that's a question I get a lot. So they're getting a lot better. Like particularly Fitbit, they're good for some things and they're not good for others. So they're really no good for sleep stages. So you just throw that in the garbage. Like they're really no good. As you see, the only way you can reliably assess sleep stages is by your brain waves. So they're estimates, if anything, and they're not very good estimates of sleep stages. So don't get too worried. I know people will sometimes come to me and be like, it says I get no REM sleep, or it says I get no deep sleep, or something like that. Don't worry about that at all. They are pretty accurate in estimating total sleep time, and then also time spent awake during the middle of the night and number. They underestimate, or no, they overestimate wakings. So if it says like, I was awake like 30 times last night. What they're trying to assess wakefulness on is the presence or absence of movement. So if you just happen to have like a really restless night, it's going to count that as wakings when you probably weren't awake. You were just moving your body, and you move your body all the time during sleep as long as you're not in REM sleep.
Great, thank you so much for clarifying. Someone was asking about naps. So they asked to confirm a nap of either 30 minutes or more than 90 minutes is ideal. And then in terms of like having a nap during the day, if your bedtime, is around 10:30, when should you try to schedule that nap so it doesn't interfere with bedtime?
Yes, so they're correct. Those would be the ideal times to make sure that you don't feel sluggish. I would say that like naps under 30 minutes are really ideal for anybody who is just needs a little bit of a quick burst or something like that. The naps of longer duration for somebody who's like a typical sleeper, those are more likely to impact your night the following your sleep that night. So for the person that would be going to bed around 10:30, a nap prior to lunch would probably have no effect on their sleep. Like a 30-minute nap prior to lunch or like right after lunch or something like that. But if you're getting into like the afternoon, or you're getting into the danger zone.
All right, perfect. Someone asked if you wake up several times in the night due to pain or have to make, multiple bathroom trips, is it, and that would affect your restorative sleep, is it good to make up for that during the day with those multiple naps?
I guess it depends on how much time they're awake during the middle of the night. So waking up is not necessarily bad as long as you can return to sleep. So in that sleep architecture graph that I showed you, like there was at least 3 times there that, you would kind of come out of sleep. So it's not, if you were to add up the amount of time you spent awake during the middle of the night, if it's less than 30 minutes, I would just ignore it. You wouldn't even need to necessarily make it up. If it's longer than 30 minutes, I would try, instead of making up for it during the day, to try and reduce the amount of time you spent awake during the middle of the night. So if there were any factors that you could, if it's pain, breakthrough pain, you might have medications that, take longer, or last in your system longer. If it's, comfort, there may be things to increase your comfort to try and reduce the awakenings. If it's your mind, getting active, and, there's ways to address that. So I'm kind of taking you through my clinical decision making. It would be like, what would you do after that? As far as making up for it, it's a risk, right? When you sleep during the day, it's a risk that you're just going to perpetuate the subsequent night, right? That sleep drive that you have built up, what that sleep drive does is it increases the amount of time you spend the next night in slow wave sleep. So you go to sleep faster and you stay in slow wave sleep longer. So your sleep on the subsequent night after being really, really sleepy is automatically of better quality. So if you don't have that strong sleep drive, you're going to compromise your subsequent night's sleep. So I would encourage you to do the minimum. What is the minimum that I can do this day just to make sure I can, function? And I'm not talking function at your optimal, just like, just function. So then the subsequent night, I can get a better night of sleep.
That's great. Thank you. So we got a few questions that came in regarding night sweat, and especially if, you had mentioned not wanting to raise that core body temperature before bed. How do you sort of combat that if you have night sweats?
So this is interesting. So, I'd want to know a little bit more if they were medication related or hormone related, because those can be a little bit different. If they're related to either, hormones in guys or girls, then, sometimes what we find is having a cool pillow. So there is actually, and I have no conflict of interest or anything like that with this, but there's something called a chillo, which can actually keep your head a little cooler than the rest of your body. So keeping a cool environment, keeping your body cool, making sure you don't have memory foam in your bed. Like, memory foam is horrible for hot flashes because you sink into the bed and then that heat is trapped around you. Because most people can have these temperature changes and not actually wake up, but your temperature has to change more than a certain threshold, and then it wakes you up. So when you're sinking in a memory foam mattress, it's certainly going to wake you up. The other thing would be what you wear. So wearing wicking clothing, not cotton clothing, because then it's going to trap and then become cold. So these are a certain number of things you can do. The other thing too, is to engage in diaphragmatic breathing when you find you wake up because of a hot flash. So you're capitalizing on the fact that your heart rate is directly tied to your respiration. And your heart rate is also influenced in your sweating. So if you engage in really purposeful diaphragmatic breathing when you wake up, sometimes you can get to sleep faster. So there's some environmental and some psychological things you can do to address hot flashes. If it is hormonal, sometimes you can even take the medication that is causing the hot flashes in the morning instead of at night. So talk to your pharmacist or your oncology team about that.
Perfect. Thank you. And yeah, we always stress, if you're having any symptoms that are impacting your sleep, to always speak to your healthcare team about that. Great. Someone asked about, and it's sort of tied into the last question, if you're on a medication or chemotherapy that's impacting your sleep, how long usually after stopping taking that medication should your sleep sort of go back to normal?
It depends how long you were on it. So, roughly 6 weeks would be a minimum before I would say, all right, with any medication change, I think 6 weeks it tends to be my bar. Now, some medications could be longer than that. And also, if you think about like diagnosis or diagnostic criteria for insomnia, you need to be having insomnia for at least 3 months before it would be considered an insomnia disorder. And so 6 weeks to 3 months would be my range of time when you'd be like, all right, you know what? I'm off this. I'm not sleeping any better. And now I should look into getting a specific treatment for my sleep.
All right, great. We had a couple people ask about backlit devices.
Mhm.
Someone said iPads offer different lighting for nighttime to try to, I guess, combat that back light.
Yeah.
Is that still considered a no-go? And does watching traditional TV fall under that buffer zone, or is that also not great?
So traditional TV, you have a pass. You can do traditional TV because traditional TV tends to be farther away and it doesn't have that same sort of light. Now, I still recommend disengaging from devices, not only because of the light, but because of the continued promotion of engagement. So like if you're on social media, you're scanning or you see a notification for an email or, you know, the devices are just encouraged to just keep you engaging with them and you want to disengage. So if it is like reading on a device with the night mode turned on, that's not as bad. But if you're playing games on your device, if you're doing social media on your device, if you're doing your email on your device, if you're searching, Google, all of those things are just keeping you engaged and aren't recommended.
Right, perfect. So we got a few questions regarding melatonin and your thoughts on taking melatonin, as well as cannabis products such as like THC or CBD.
Mhm. Both really good questions. So melatonin for people with insomnia are no better than placebo. So that's an easy question. So melatonin is only endorsed in people with circadian rhythm sleep disorders, people who work shift work, and people who have jet lag. For people with insomnia or people who can't sleep, it's not because they're not producing enough melatonin. It's usually because of something else. It's because of arousal. It's because of behaviors. It's because of physical things. It's not usually because they're not producing melatonin. So, as far as THC or CBD, I'm actually proposing a study right now to look at cancer, people who've had cancer and their cannabis use specifically for sleep. This is a individual thing. Some people are going to have used it and they like it and it works for them. The mechanism is probably, that it helps them relax, right? It helps kind of calm their mind, and that's what they use it for. But other people are going to find that it makes their mind go faster. And so there's no real one answer. It's dependent on the person. It's dependent on the type of CBD or THC and the formulation and everything else like that. But for some people, it can be helpful. For some people, it's not. So it's definitely not like a cure-all.
All right, perfect. And I'm sure those are two sort of treatments that they'd want to speak to their healthcare team about
Mhm.
starting. All right. Still going through a lot of questions. Again, thank you all so much for submitting them. Really interesting ones. Um, so someone's talking about their sleep apnea and waking up at night and not getting back to sleep. You talked a little bit about, what happens if you have long wake periods at night, but can you touch upon that a little bit more, especially if it relates to the sleep apnea?
Mhm. And you can have sleep apnea and insomnia. Those two things can become comorbid where, you might well, depending on if the person is on treatment for their sleep apnea. If the sleep apnea is treated and the person still wakes up, or if it is in fact the apnea that is waking them up and then they're unable to fall back asleep, I think, I'd want to make sure that the apnea was well treated. And then the same mechanisms, the same reasons can happen where, your mind turns on and then you're awake once the apnea wakes you up. And so then the two treatments together would be make sure that your sleep apnea is well treated, and then engage in treatment for insomnia, which would be to, take all of the worries out of the bedroom, to reassociate the bed with successful sleep, over a period of, weeks. And then, hopefully both conditions would be taken care of by then.
Right, perfect. So we got a few questions about regarding children who are undergoing cancer treatment, especially if they're taking something like prednisone or another steroid. Do you have any, I guess, recommendations for younger people who may be experiencing sleep, disturbances or not getting enough sleep?
Yeah, so kids, I'll say that my nephew was diagnosed with leukemia when he was 4, so I have some lived experience with this, and kids. It's a little bit different because of like napping. You just try and get it when you can get it. I think with kids, it's a bit more like, you do what you need to do to survive during that period, and then, handle the repercussions later. So with kids, you might find it that you're recommended to use melatonin as something that's helpful for kids. But again, that would be like the oncology team would have to work with that. I think with hospitals, especially if they're in hospital, trying to differentiate the bed from the place that they play. Like, so, trying to reserve the bed for sleep can be hard in hospital, but trying to do that as much as possible. Sometimes even just getting in different clothes from their sleeping clothes, from getting on top of the covers versus under the covers or something, trying to help them differentiate night and day just by like the behaviors that you're engaging in. That can help them have better circadian alignment, circadian entrainment that way. Thinking about other things that can help with, I think about the parents too, when I think about the kids, right? Because if the kids aren't sleeping, then the parents aren't sleeping. And if the parents aren't sleeping, right, like that's where some of the distress comes in as well. So making sure that the parents are taking shifts, where if it's possible, somebody is able to recover some of their sleep, on the next night if they were up with their child, having disrupt sleep. So I think about making sure that the parents are really taking care and prioritizing their sleep, or at least, having enough support where there's other people that can come in and assist when the kid is undergoing that active chemotherapy.
Perfect. So I think we have time for one more quick question. I know a lot of people have been asking about the medication as zopiclone,
Mm.
and if that, sort of what your thoughts on that, when to start it, when to stop it, especially for those that are diagnosed with blood cancer.
hmm Yeah, so that's one of those medications that can be used for short-term periods, right? It's a non-benzodiazepine type sleeping medication. It's thought to be less dependence promoting than some of the benzodiazepines and some of the other sleeping medications, but it is still meant to be used short-term. If you use it properly, then you want to use it about a half an hour before your intended sleep window. So in that, case that I said, it would be like if your sleep window is 11, you would take it about 10:30. People make the mistake of taking it too early, and then a lot of the medication has worn off before they even have enough sleep drive for it to become effective. So, but yeah, trying to not rely on it, making sure that you've got other things that you can do, because it really is intended for that acute insomnia period, not the short term, not the long term.
Right, perfect. Well, thank you so much, Dr. Garland, for being with us here today and for really diving into this important topic and tackling some of the important questions that came in. If you can go to the next slide, please.
Oh,
Perfect. So we'd also like to thank those who made this conference possible. We want to thank our marquee sponsors, Astellas, as well as AbbVie, AstraZeneca, Bristol Myers Squibb, Janssen, Jazz Pharmaceuticals, Merck, Novartis, Paladin, and Pfizer. Next slide, please. So before we sign off, we'd like to remind you that you are not alone. We are here for you. Please reach out to us for more information about any of our services by calling the toll-free number as on the screen, as well as sending us an email. Also, stay tuned for the other sessions that are taking place throughout the week. For example, our next session, When Cancer Takes an Emotional Toll on You, is scheduled for today at 3 p.m. Eastern Time. It's not too late to register for any of our upcoming sessions. You can visit bloodcancers-conference.ca to register, or you can send one of the community services managers an email too, and we can send you the links. So thank you all so much. I hope you have a wonderful day and stay safe.